Hello everyone and welcome to ADO's October webinar. As you can see, October is designated as Depression Awareness Month. But what causes depression, how is it diagnosed, and how is it treated? To help us answer those questions and hopefully lift our spirits is today's speaker. He's Clinical Assistant Professor from Georgetown University and ADO's Medical Director, Dr. Howard Zahalsky. Welcome, Dr. Zahalsky, and thank you for joining us today.
Thank you, Tom. So today we're going to talk about a very important topic, depression. And we're going to start with this poor gentleman who clearly suffers from depression or some other horrible thing that is bothering him. So I just want to say that start by saying that there is a huge difference between depression and being sad, particularly being sad over something such as the loss of a family member, a traumatic incident, which we put as a whole separate category of condition called either adjustment disorder, reactive disorder, or grief. Depression is that overwhelming sadness that you feel when everything else seems to be pointing in a good direction. If you lose your job and you're stressed that you might not be able to make your house payment, that's normal and appropriate. That's actually a good response that stimulates you to try and solve the problem. If your father just died and you're upset and you loved your father, that's normal grief. And it's supposed to last a certain amount of time. We usually medically give it up to 6 months, although it's more typical 6 weeks, and then you have to be able to get back on with your life. Depression, clinical depression, is that kind of sadness when there isn't a loss in the family, when you haven't just lost your job, when everything seems to be otherwise normal in your life. Now, not everyone's life is the same. Lots of people have chronic stress in their lives. Maybe you don't love your job. Maybe you have a chronically ill child. Most people, though, are able to handle those challenges in life to one degree or another and still remain functional. It's whether you can't handle life's normal or even maybe a couple of standard deviations above normal stresses, or life seems to be going well, yet you're still miserable all the time, is when we start to classify it as a depressive disorder or major depression. Now, how serious is this both to the person and to the community as a whole? And we'll start to get a feeling for that on the next slide. So here is worldwide the suicide rates and the homicide rates per 100,000 people in lots of different countries. Now you can see way at the left is Colombia, but most of its bar is red, which means most of the deaths due to suicides and homicides are on the homicide side of things. The United States is about 40% of the way from the left side. As you can see, our line, which is slightly above average for all of these countries, is slightly more blue than red, which means per 100,000 people in our country, you are more likely to die because you killed yourself, because you committed suicide, than you are to get killed by somebody else, which shows just what a problem suicides are. You're more likely to get killed by yourself than you are by somebody else in our country. Again, we're looking at the suicide rates per 100,000 people by gender. There's two important things that I want to take away from this slide. Number one, red is male and yellow is female. The blue is the total average. You can see that the red line is higher than the yellow line. Now, this doesn't necessarily mean that depression is more common in women than men, but suicide definitely is more common in women than men consistently over the course of this graph from 1950 to 2005. A second important message I want you to take away from this graph is the lines are fairly flat. The male line seemed to have gone up a little bit towards 1990, maybe come down a little bit. The female line seemed to come up a little bit in the 1970s and then come down a little bit. But from the beginning to the end of this line, these lines are fairly flat, which means we have made very, very little progress in the treatment of depression and the consequences of it, namely suicide, since the 1950s. We've had so many medical advances, MRIs, antibiotics even over this course of time. But for depression and suicides, we've done very little good. Now, it goes beyond just the fact that you can get killed from depression, that you can commit suicide. There are a lot of other implications to our society from this level of depression that is throughout our country. There was a University of Michigan study done on data from 2000, which estimated that $52 billion in lost productivity per year is a result of depression, and that the typical depressed person misses 9 days a year of work and is less productive when they are there, accounting for this dramatic decrease in productivity as a result of depression. That puts depression as a cause of less productivity ahead of heart disease, ahead of diabetes, and ahead of low back pain in terms of a condition that keeps people out of work and makes them less productive while they are at work. So it's clearly both for the individual and society a condition that does need more attention, and that you would hope over the last 60 to 70 years we would have made some more progress. Now, specifically beyond depression, there is a specific type of depression that I want to take a look at, and we'll see on the next slide. So this is a happy mom with her baby. This is the untold story of postpartum depression. This is what everyone imagines a mom with a happy, winged, dressed-up one-year-old is supposed to look like. Happy, joyful, everything's peaches and cream. This is unfortunately how many of those moms are feeling. Postpartum depression is one of those sinister hidden diseases in our society, in no small part because there is such a social stigma associated with postpartum depression. Moms in particular, but sometimes fathers as well, feel like they're supposed to love being a mom. They're supposed to love breastfeeding. They're supposed to love bonding with their baby, even if their baby's waking up 7 times a night and causing them tremendous sleep deprivation. And when they start to feel like you see on the screen, they don't know who to turn to, and they feel like they are losing and that they're giving up on their baby and that they're giving up on their family if they admit to being depressed. While the depression is really more than just a reaction to the baby. Remember, we talked at the beginning, depression is not strictly a reaction to any specific thing. It's a biochemical problem that to some degree is independent of the stressor. So even though sleep deprivation in babies might bring it out, it's actually a biochemical problem and should be treated as such and should not be looked on with the social stigma that many moms and those judging the moms seem to do. So how do we diagnose depression? More and more doctors are doing depression screens, and in fact, the Obamacare move towards electronic medical records, one of their mandates is regular depression screening, particularly in the postpartum period. So many doctors are giving out these screens to patients when they show up in the office, regardless of what they're showing up in the office for. And I'm not going to read down the entire list of 20, but you can see I feel that my heart beats faster than usual. I get tired for no reason. I feel that I'm useful and needed. These are all different facets of depression that, if you say you're having too many of these, might indicate to the doctor that they should ask you some more questions to determine if you have depression. All right, so now you're a doctor like me, and you have either a new mom or even someone who is just struggling with their normal life. You've given them a depression screen, and you think that they might have depression. What is the next step? So there are many, many medicine options for depression. There are certainly patients who want to try therapy, hypnosis, even just stress reduction and going on vacation. But for real, true, major depression, medicine really is, in my opinion, the right way to go. Because again, this is not a problem of a specific stressor. It's not a problem of a specific event. It's a biochemical process, and it needs to be treated as such. And we'll see why on the next slide. So this is a medical slide here. What we're looking at is 2 nerve cells. The top nerve cell, which is in the kind of light pink, is talking to the bottom nerve cell, which kind of has those squiggly lines in the middle of it. Your brain, one cell in your brain talks to the other cell, and generally speaking, one cell is trying to tell the next cell to be happy. How does one cell tell the next cell to be happy? Well, there is a chemical that the cells use to talk that is called serotonin. The top cell releases the serotonin, which is those tiny little bluish-greenish dots, and the serotonin travels across that little space called the synapse between the two cells and tells the next cell to be happy. People with depression have reduced serotonin. They just don't have as much serotonin as the next person, which means they are unable to keep their brain happy. Their brain is unable to tell itself to be happy. It's not a matter of weakness. It's not a matter of their life has more stresses than somebody else. It is literally they don't have enough of this chemical serotonin. What the medicines do is it increases the amount of serotonin that is in that synapse area. It causes your body to keep the serotonin in the synapse longer. You see, your body releases the serotonin into the synapse. The first cell releases the serotonin, but then it doesn't like it if the serotonin stays around too long, and so starts to sweep it up. It reduces that sweeping it up mechanism so that the serotonin that is released stays around longer and basically talks louder to the second cell that it should be happy, and will increase your brain's happiness, which will decrease clinical depression in the patient. So these medicines that increase the serotonin in the synapse and make your brain happier, they work really, really well. So why has the trend line not improved much since 1950 in terms of treatment of depression? Well, one of the big reasons is, as you can see here, the patient fights against you. The patients who have major depression, many of them don't want treatment. We already talked that in the postpartum depression crowd, a lot of people don't want treatment because they don't even want to admit there's a problem. They don't want anyone to think that they don't love their baby enough to be happy. Other people think that it's just their stress level, that they're just under more stress than the next person, and once they get over the next project, the next class in school, once their kids get a little bit older, or once they change jobs, things will be better. And many, many people don't want treatment for depression because they think it talks to an intellectual weakness in them. Nothing is as uniquely you as your brain. If your heart isn't working right, you can deal with taking medicine to make your heart better. It's your heart. If your lungs aren't working well, no one has a problem taking inhalers to make their lungs better. But if your brain isn't working right, it speaks to an internal weakness in you that you don't want to admit to. You don't want to think of anyone changing your brain because your brain and your emotions is who you are. We have got to get over that way of thinking. And if you take nothing from this webinar, take that this isn't a personal failing that you have depression. This is a chemical problem just as much as type 1 diabetes, just as much as genetically high cholesterol. This isn't your fault that you have depression. This is a chemical problem, just like many other chemical problems that you would take medicine for, and that you need medication because you can't think your way out of depression. You can't battle through and be strong enough to get out of depression. You need help, and you need to accept the help so that you don't become one of those statistics. And if you accept the help and take the medication, then maybe we can help you to become the person who you see on the next slide, back to the happy you, which will make you a better parent for your children, a better child for your parents, a better and more productive worker, and someone who you will enjoy living with yourself. So, now that we've learned a little bit more about depression, how can Activ Doctors Online help you if you or a loved one is battling with depression? And Activ Doctors Online has several solutions that can be very helpful with depression. The first is our online personal health records. Patients with depression see and oftentimes see a lot of different doctors, mainly because they don't want to accept the treatment from the first doctor and so end up wandering doctor to doctor. Having all of your records in one place so that individual doctors can see the results, the treatments, the medications given by those who came before them will get you much faster onto the track for health and on the right combination of medications to battle your depression. Second, we have our second medical opinions. Should you have a difficult case, not every case is the same. Not every diabetic needs the same medication. Not every person with high blood pressure needs the same medication. And not everyone with depression needs the same medicine or responds well. So if you're battling with a particularly tough case of depression and want to be put in touch online with one of our top specialists from around the country and around the world, we have the technology to make that happen. And finally, with our e-consultations, if your doctor is a member of Activ Doctors Online, this will allow for virtual visits so that you can get in touch with your doctor and tell him how you're doing. Most of treating depression is talking to somebody. It's not like you have to draw blood for a depression level or use a thermometer to check exactly how depressed you are. This is communication, and it can save both doctors and patients a lot of time to do those kind of visits virtually if you and your doctor are both a member of Activ Doctors Online. So those are our solutions. And now I'm going to turn it back over to Tom, who can tell us a little bit more about Activ Doctors' vision and how to get started with Activ Doctors Online.
Well, thank you, Dr. Zahalsky, for another great presentation. Here at Activ Doctors Online, our vision is to reinvent healthcare by providing user-friendly mobile health solutions that allow people all over the world to live healthier, safer, and more productive lives. We strive to educate, engage, and empower our members to take control of their health destiny to save time, money, and even lives. We hope you've enjoyed today's presentation, and we invite you to start a free 30-day trial over at activdoctorsonline.com and by clicking Get Started. For more information, to schedule a demo, or if you have any questions about our service, please feel free to contact Activ Doctors Online using the information on screen. We're also available via all the major social media platforms. Thank you for watching, and we look forward to seeing you next month for another informative health webinar.